All right. I hope everyone enjoyed that little interlude. Off the top, apologies for the technical problem here. As some of you may have just heard, I had thought we would be able to have everyone's webcam up at the same time, but apparently not, and I don't really have time to figure out why at the moment. So we're just going to go with what we have here. I want to thank everyone for attending. We have a lot to cover in a brief period of time, so just a few notes from me off the top. We are recording this, and it will be available for anyone to watch later through the webinars page on our website. That's jco-online.com. We also are going to do questions, but we are going to do them at the end because we want to try to get through everything first. So if you can just hold those till the end. And I think an important topic here is, so today we are not going to really talk very much about the getting back to work aspect of this when the stay-at-home orders lift and you can resume some sort of more normal practice. We didn't think we had time to do it justice today with everything else, and we want to have a clear picture of what the world's going to look like, but we are going to do an entire webinar just on that topic very soon. And we will publicize that webinar through the same channels as this one. It will be free, just like this one, and you can always look to our website for updates on that. Finally, we also will be posting some resources on our Facebook page. In particular, you can look for some information from McGill showing up there later today. So with that, I'll introduce Dr. Maru and we'll get going.
Awesome. Thank you, Phil, and good morning, everyone. We really appreciate you joining us to discuss the COVID-19 pandemic and some best practices to take back to your office to deal with this unprecedented event. We at the JCO are honored to have some of the brightest and most influential orthodontists in the world joining us for this webinar. Despite the fact that you can only see 6 of us, there are 9 of us here and 8 panelists. By way of introduction, we have Dr. Luis Carrieri from Barcelona, Spain, Dr. Mauro Cosani from La Spezia, Italy, Dr. Jeremy Fry from the Kansas City area, Dr. Gail Glenn from Dallas, Dr. John Graham from Salt Lake City, Utah, Dr. Neil Kravitz from the Washington, D.C. area, Dr. Mark Lemchen from New York City, as well as Mr. Wes Lyon from the McGill Advisory Group. So this webinar will have 4 segments: clinical best practices, financial best practices, community aid, and a question and answer segment at the end. As Phil stated, feel free to submit questions as we go so you don't forget them, but we will be answering them at the end and we'll answer as many as we can. So not to keep you waiting any longer, let's kick it off with a discussion on virtual appointments, starting with software by Dr. Graham. The time is now yours.
Mike, thank you very much for the introduction, and I wanted to thank Phil for setting this up. This is a pretty monumental task, and it's a lot of people who are attending, and so it's my pleasure to be asked to be a part of it as one of the contributing editors. I don't want to speak much about specific software companies. The reason being, there are so many of them now that are making scheduling software available. All dental and orthodontic practice management software companies either already have scheduling software available and they are live with it, or it's in the pipeline, because it's becoming an expectation of patients. And so I would encourage everybody, I mean, a simple Google search for top 10 orthodontic scheduling software, patient scheduling software will bring up more information than you could possibly want to gather. What I wanted to just talk about very briefly is, how do you do that as far as an orthodontist and in your practice? How do you introduce it to your patients, and how do you make it work, especially right now? We're going to be talking specifically about this unprecedented shutdown of every orthodontic office in the country. And I think that most important, and not just for the scheduling aspect, but the most important as far as staying connected with your patients, marketing, which is going to be very important as we're trying to kickstart practices back up someday. is staying in touch with your patients. And so I could only offer a couple of suggestions, a couple of things that I've done and that I've seen other people do. I think probably the most important thing is getting the word out that you are accepting either virtual consults, or you're allowing patients to schedule those consults, or to schedule actual brief virtual checks where you're able to look inside somebody's mouth. And so I think the very best way to do that, if you haven't done it already, is to get on one of your social media platforms and start making it a regular occurrence, so that patients have a feeling of routine with you, knowing that they are going to be able to see you or see a recorded episode, so to speak, of a connection that you've made with your patients. I've done that. I did it very recently. One of the things that we decided to do as an office is that for individuals that wanted to, that were feeling the pressure of not working, that we would temporarily suspend their payments, but only if they requested it. We weren't going to do it across the board. And so I just jumped on very quickly, and I did just a little Instagram post. It wasn't even a live post, but this is something that I would recommend that everybody does when you're introducing scheduling or setting up appointments for your patients. Just jumping on and letting them know, and make sure that you're broadcasting it not only with Instagram, but it simultaneously posts to your Facebook feed. And that way your patients have access to you, and they can turn to that if they call your office and someone's manning the phones. Then your office staff can direct them to either the Instagram post or the Facebook post that you just did, discussing scheduling or consultations or whatever you want to do. I think one of the things that a lot of software companies are doing now, as far as virtual scheduling and virtual visits and patients scheduling those visits, is allowing patients to pick a time, and you're able to make available through almost all of the software. You're able to make available a virtual waiting room, so to speak, where a patient will then click on the link. It will take them to a sort of a holding area, much like Zoom and other places have for people. And then the doctor, whoever is monitoring this, can see the patients that are sitting in queue, and then you can click on it. I think one of the things that's very important is to keep them brief, much like I'm going to do with my comments today. Keep them brief, because you've got a lot of patients, and what you don't want to do is set a precedent that you're going to hang out with a patient for the next 45 minutes, because that's kind of what they're used to doing in your live practice. They need to understand that this is an unusual circumstances and that you need to get back to seeing other patients. All of these things can be communicated with your with your social media platforms. And I've seen quite a few orthodontists, and I think it's a fantastic idea, who have made a small keynote or PowerPoint presentation that they've then exported and put on Instagram and Facebook, that gives instructions to the patients, no more than 4 steps. Don't go beyond that, maybe 5 at the very most. Just telling them, click on this bright orange link. You will be in a waiting room. Pick a time, whatever you need to do as far as instructions go. And then make sure that it's very clear that you're not doing this 7 days a week, unless you are doing it 7 days a week, and make the instructions quite clear as to when you're going to be offering virtual appointments. I think it's something that we all need to come to terms with, because we have no idea how long we're going to be in this state of affairs. I think a lot of people are hopeful that it'll be by mid to end of April. I don't think it will. I don't even know if it's going to be mid to end of May. And some states like Oregon, they've had a state mandate that they can't even consider going back to work until, I think it's June 15th. And so I think something that we all ought to come to terms with and be on the progressive side of things, and be proactive in seeking out software solutions. And then if you have questions about it, any number of Facebook groups that most of you belong to, just ask, and you've got plenty of orthodontists that are more than happy to share their experiences. So with that, I'm going to mute myself and move on.
Thanks, Dr. Graham. Just a question to the others in this part of the panel. Has there been a specific software that you have used? I mean, I know there's 10, 11, 12 of them out there, and there's more popping up every day. I'm seeing them on my Instagram feed. But is there something that you have used that has worked well, or that is simple for an orthodontist who doesn't have a starting point to begin?
I guess I could jump in and maybe give you a little history of what we've done and what we have chosen to use in terms of our software. So we kind of went down this, my history really with virtual is really only with exams. We do that primarily. Last year, we did about 500 video exams. These are patients that had never been in the office before, and we wanted to try to reach patients that, you know, we were finding weren't showing up for new exams and trying to meet them where they wanted to be met. We really had really three goals in going down this road. Number one, we wanted to make sure it was systematic. We have 16 practices in 3 states and trying to figure out how we can do this in a way that we can be replicable. Number two, easy for patients. And number three, really decreases the barriers to start treatment. And we decided to kind of do a trial run with some software that really wasn't proprietary to orthodontics. We put an interface on our website with a very kind of clunky internet widget called Bookly, which allows us to go in on the back side of our website and actually have blocked off time. So you can do it 5 days a week, you can do it 7 days a week, you can do it between the hours of 1 and 4, you can do whatever you want. Stimulates emails to both myself and to person in our business office that's handling all of the TC work for those new exam patients. And we use FaceTime for that, or Skype, and this is a big question. I'm on the AAO Future Think Tank board meeting, and we've been asking this question with things going more video. What's going to be the HIPAA compliant solution for decreasing barriers for patients and making it easy for patients? Right now, I don't think is one that's not clunky, and so we still just use FaceTime and Skype. It works really well for us. I think there's some risk.
I'll jump in and make a quick comment, Jeremy. I think most people are aware, at least at this point now, that the HIPAA compliance has been completely loosened during this unprecedented time. So if there is ever a time that you wanted to experiment with different platforms, now is the time to do it, because they don't necessarily need to be HIPAA compliant. That'll change, obviously, once we're back in action in our offices. But right now, the HIPAA guidelines have virtually disappeared, and you can look that up on Google. You can go straight to the Department of Health and Human Services, and they have a big commentary on that.
I agree. I think it's a great point. I'm personally looking at it for this crisis as well as what's going to happen in the future. And I don't think there is a good solution there yet for that once they kind of clamp back down. But that's been our experience, and I'll step off and let Luis talk.
Yeah, what I was thank you, Dr. Fry. What I was going to tell is how we have been doing in the last years with the patients. No, many appointments that were not really necessary for them to come were monitored by a simple platform that is a message type WhatsApp. What we give is I give personally my personal number to the patients. So it's amazing because you think that they will start calling you at every time, and they never call. It's something super interesting. So you can give perfectly your telephone that the patient will respect this amazingly. And it has been working so well because it's very easy. We ask to the patient to send a picture of the occlusion, and we say, okay, and this is giving you the possibility of writing on top of the picture and making diagrams and explaining how, in an easy way, in an easy platform, how to work with these emergencies or monitorize the procedures of the treatment during the orthodontic process. No. And another interesting point is that those patients that really need to have the access to these technologies, all of them feel that you are so close to them. We have never been so far, and at the same time, physically so far, we cannot touch our patients, but physically, but virtually, we are so close. So this compensates the lack of presence, of physical presence of your doctor. Huh?
Perfect.
That's a great point, Louis. That's really well put.
I love that. Thank you both.
Thank you.
Let's move into the last part of the virtual appointment section. And this is for Dr. Lemchin and Dr. Kozani to answer. Which patients are we looking at? What type of appointments do you think this works best for?
Okay, well, let me just overlap it into the last discussion a little bit. In our office, we looked at a number of these programs. We looked at Zoom, we looked at Doxy. We have been using Join.me for a long time. We ended up going with Zoom because it was easier to set up. They have a HIPAA compliant program, which runs you around $200 a month for 10 licenses, so you can get everybody into it. It's encrypted, and it's easy to invite people with one click, so that's where we input. As far as the patients that, who are we doing this with and how do we do it? Our remote clinicians, we put a lot of people on remote clinicians, and we're paying them for the hours they work, and they have limited hours, so we assign a doctor and a clinician to each day based on the clinician's allotted hours. So for instance, on Mondays, I'm seeing virtual visits. I have one clinician that's assigned to that project. They send out an email to the patient the night before to let them know how to prepare for this visit. And we have a very cute little video that Dr. Sulzer did of her doing a virtual visit with her daughter, giving them instructions about everything from, well, I'll go over the instructions in a second. So they'll do that. And the TC or the assistant calls the patient 10 minutes prior to the time I'm supposed to get on to make sure they're all set up. They have everything that they need together, and that I have the chart up on my desktop and on my computer, and the assistant really has the hosting capabilities to control the waiting room that we have, the virtual waiting room. The virtual waiting room is important also because it is a security issue that no one gets into the visit unless you allow them in from the waiting room. So this addresses the security issue of Zoom. And they do have passwords now if you want. So they'll call me, they'll say, we're ready for the visit. They'll invite me into the room at that point, and then I will look at the patient on the screen, and we'll do a little exam or answer their question, whatever it might be. And just as an aside, also we've had to decide whether we're going to charge patients for these visits or not. So each individual one, we can see whether it's a visit that they should be charged for or not. Most of them we do not charge for. So the steps involved in this are that they call the patient to prep them for the visit on Zoom. They ask the patient to wash their hands, get any appliances or elastics prepared next to them. We ask them to maybe get 2 spoons out to help retract the cheek. If you get them to get old spoons and fold the spoon, bend the spoons back, they're just like retractors. You put 1 spoon on one side, 1 on the other, and pull back. Staple spoons work really well. We ask them to have a flashlight or use their cell phone light because the lighting is the most difficult thing. And once they've done all these things, then they bring me into the room at that point. So I don't have to be there for all that. As I'm talking to the patient and asking them to show me this, show me that, they take notes into the chart. So they're writing everything up. I have my little meeting with the patient. I tell them, answer their question, a broken bracket, a tooth they think is moving too fast or too slow, change the elastic pattern. And once I'm done, I say, be safe, take care, we hope to see you soon. And I leave the visit. The treatment coordinator or assistant is still in that visit. She finishes the appointment with them, schedules the next visit as we've decided whether it's going to be another virtual visit or whether we're going to try to hang on until we see him again. And then sends them an email recapping the appointment and what went on. We schedule about 30 minutes for each of these visits, although I think of my time, they maybe take 5 to 10 minutes. And we generally do about 48 of them weekly. So there's not a lot of them, but that's what we're doing. So that's how we're scheduling those appointments. We set up a special template for virtual visits. So we now have, our 2 different office locations on our schedule, and another schedule is called virtual visits. And that's my part of this presentation. And so now we'll move to Neil. I think you're doing the next.
Excellent. No, I appreciate that very much, Dr. Lemchin. As we move to the next section, let's talk about patients where this might not work. For Dr. Glenn and Dr. Kozani, which patients are we seeing that there might be challenges with virtual appointments?
Ladies first.
One thing that I'll bring up is that, with the offices being closed, how do we handle patients that really need to be seen? And the AAO has been very clear to tell us that emergency orthodontic care includes relieving pain or infection, something that's trauma related or is critically necessary to prevent harm to the patient. And yet they do give us the leeway to say that we can use our professional judgment to determine what patients' needs are urgent or emergency care. Dr. Kozani, do you have thoughts on that?
Absolutely correct. That is exactly what we are doing. And actually, also, our association gave us the same guidelines. And we just see what is emergency. And what we define as emergency is something that if you don't go to the office, you go to the hospital. It's something that is the real emergency, the significant emergency. It's not a bracket that pop off. It's we are maybe 2 weeks a little bit in advance of the United States and maybe other countries, and believe me, this is not a joke. It's something that is real and is really affecting us very, very hard. We are the profession that is working exactly where the virus is. So we have to really pay attention to this. And, I'm glad that you're going to talk, probably we are going to talk, or you're going to talk about what the restart. But, that is something that is something that we are facing now. But so far, at the beginning, what we are trying to see is exactly what is an emergency. But unfortunately, there are also something else. There are people that have cantilever in their mouths. There are people that have something active in their mouths. And, it's something that not easy to deal with. Not easy to deal with in remote. So sometimes you have to think what emergency in a different perspective. What you do if you leave something active in the mouth for a long time. And that is something that has to be evaluated very well, because you have guidelines for your association. You know that you can be somehow somebody that spread the virus, but you know that you have something in the mouth. So at this point, maybe when we're going to talk about how do we deal with emergency, we can talk about what we do and what we have learned out of this disease in the orthodontic office.
So, Dr. Kozani, you bring up a very good point, and we were going to talk about this a little bit later, but since we've already started it, let's talk about it right now. We know what an emergency is, a poking wire or something that, an appliance that's halfway out. But at what point do all of our patients turn into emergencies for the exact reason that you just said? You have a nitinol wire in there, 1925, and it's continually expanding, or if you have an expanded stainless steel wire in there. At what point must we see just a normal wire adjustment back as to not cause harm?
I'm really sorry to tell you that you should have already done it. Now, when something happened in Italy, we did a triage on our patients. And in triage, we said, what are the patients that we have to see and what are the patients that can be postponed? So before everything was closed, what we did, we were acting on this patient that we could not postpone. And so make something that was active, less active, or doing something, but that, in my opinion, was something that, we are too late now. Because if you want to work on the patient now, you have to be really.
May I make a comment here? And that's a really good point, Mario. And I mean, you're at the tip of the spear. Sadly, you know, when it comes, Spain's not that far behind either. Luis is going to be in the danger zone, or already is. But unfortunately, if you go on the American Dental Association's website, they have a thing they've created for this: what constitutes an emergency. And I wish they would have coordinated with the AAO a little bit better than at least they did, because this is also patient facing. But there's only 3 things that they put here as dental emergencies: uncontrolled bleeding, cellulitis or diffuse soft tissue bacterial infection with intra or extraoral swelling that potentially compromises the patient's airway, and number 3, trauma involving facial bones potentially compromising the patient's airway. Apparently, if you have a facial fracture but it's not compromising your airway, that's not an emergency, according to the American Dental Association. And then they have it broken down into then urgent dental care, other urgent dental care, which no mention of orthodontics in any 3 of those categories on the ADA's website. And in fact, they have a whole section underneath that's called dental non-emergency procedures. And that is finally at point 3 under that, where you find orthodontic procedures, other than those to address acute issues like pain, infection, or trauma. The only reason that's troubling to me, and the only reason that I bring that up, is because this is on the ADA's website and it's patient facing. So I think we need to make sure, for those of our patients that are going to be reading or watching that, we need to be ready and at least be versed in what the ADA considers to be dental emergencies, so that if they bring that up, we're not caught unaware of what our parent organization is actually putting out there in front of patients.
Dr. Graham, follow up on that. Oh, so
yeah.
For example, an impacted canine, you're ligating that every 3 to 5 weeks, depending on your protocol. Would something like that be considered an emergency?
That's a really good question. In fact, I have one of those patients right now, and I think that you have to just use your discretion. Me personally, I'm seeing that patient because the problem being that patient is also supposed to be, as soon as all of these restrictions lift, that patient is leaving on an LDS Mormon mission for 2 years, and that can't be the situation where they still have a canine that's halfway in, halfway out, that I've already started activating. So at least for me, I have rationalized that as an emergency. But I'll tell you something, there are, in a large practice that I have, I think that we've probably physically seen maybe 3 patients in the last 2.5 weeks. So we're pretty serious about what constitutes an emergency, but that's a perfect question. And unfortunately, this young man is in a situation where I have to categorize that, at least for me, as an emergency. That's just kind of a personal choice.
Excellent, thank you. Dr. Glenn, any other thoughts on that?
I did speak with leadership of the AAO recently, and they were able to get that information on the ADA website that did say orthodontists to use their, or dentists in general, but orthodontists specifically, to use their professional judgment in determining a patient's need for urgent or emergency care. So Dr. Graham, I think that's where you can justify what you're doing. And I think that that's going to be more important as this situation moves forward and patients have gone longer and we've not had a chance to see them. And as Mike's question originally is, at what point in time do all these people almost become an emergency?
That's a very good point. And I'll just read the line that they put under dental emergency that you're referring to, Gail. It says, this guidance may change as the COVID-19 pandemic progresses. Dentists should use their professional judgment in determining a patient's need for urgent or emergency care. So, I mean, I think that at least from a legal standpoint anyway, probably covers all of us.
Excellent.
I don't think they're going to be that hard on us. You know, they're going to leave us a lot of latitude. I think we're reading into it. The ADA did have something on one of the recent things. It was on the bottom left-hand corner, the last thing that said active appliances or active orthodontic appliances. So they made some recognition of that problem. I think And the New York State said that anything that's piercing the mucosa is an emergency. But I don't think they're going to come down on somebody. I mean, certainly if you're scheduling your normal reties and adjustments and they found out about it, they would probably be upset, but they're going to leave our judgment pretty open, I think.
I think you're absolutely right, Mark. It's a good point.
Excellent. There was a remaining question in this section that I'd like to talk to Dr. Kravitz about. When we're looking at virtual appointments and we're, especially in the exam phase, adult versus growing patients, what are you doing, Dr. Kravitz? And, when we don't have an X-ray, I mean, a lot of early exams are looking at impacted canines, crowding and things. What are you doing specifically?
Yeah, I feel like I'm the youngest, oldest person in this group. I am pretty against virtual consultations. I had a mother just a few days ago really ask me repeatedly for a virtual consult because her scheduled appointment that was in March got pushed back to June. So she begged for this virtual consult. So we did so. The child is 10 years old. She still had her deciduous canines in. I asked her to wiggle those canines. They were not mobile. And then mom tells me that she has a family history, her and her sisters, of impacted canines. We know there's a female, increased incidence in females. So again, that's a wasted consult because I need to see her and I need to see X-rays. And I reached out to the pediatric dentist. They didn't have a panoramic X-ray for the last 2 years. So I just said to myself, what am I even doing with this consult? So I told the mom it was great meeting her. I will see her in June. And so I'm against it. I think, listen, I have no problem walking families through emergency visits, but as I've said 1,000 times, I am average even when I'm present. I make mistakes. I misdiagnose bone loss. I miss problems even when I'm present, and I don't feel comfortable being absent. There are pathologies. There are bone loss in adults, and I'm not at the point where it's worth it to me to do virtual consultations. I think it's very in vogue. It's very popular. There's a lot of push toward it. And it's not for the 99% of cases that are easy, but it is for the one case where there is a traumatic bone cyst that you're not seeing. And then all of a sudden treatment starts and you're in the middle of treatment and 6 months go by before you really take full comprehensive records. It's not what I want to do. These patients can wait. And I am using virtual appointments to walk families through emergencies to try to minimize the number of true emergency appointments that I have in my practice. So I made the decision. I know it's hard. I think the problem that we're having is we're getting into what we call financial emergencies. We have patients who are saying, listen, I'm still getting billed every month and you're not seeing me. Right. And then there's a bigger problem on that end. But really, the only patients other than appliances coming out, which I am seeing, and I'm just removing them. So if a herpst gets loose, I'm just removing it. I don't pick up the handpiece. I'm in and out in seconds because, truth be told, my family doesn't really want me doing the appointments. It's really hard for even to justify to my wife why I'm going in. But the only active patient that is not an emergency that I am seeing are surgical cases that I'm blown away, still have their surgical dates scheduled for the summer, and I have to get them ready. I'm actually blown away that they still have a surgery date scheduled. But those are really the only patients that I'm seeing, and for consults, I'm out. And if they choose somebody else because they'll do a consult, then it's okay. It's okay.
I just want to make one quick point that Coach Belichick just made, and that is that our patients are going to start feeling a lot more angst when it comes to being 2-3 months. They're still getting bills from us, and that's why I mentioned earlier. And I don't think it's a bad idea. I don't think you should do it across the board, but I think it's nice to offer just with a quick Instagram post saying, listen, if you're in financial straits because you've lost a job or you're not working right now, please reach out to our office, and we will put a temporary, and emphasize that, a temporary pause on your monthly payments. But you need to reach out to our office so that we can make those arrangements for you. I think that's kind of a nice thing to do. I'll tell you that when I did that about a week and a half ago. I think we've had 3 patients that called us. So again, just like Coach said earlier, they're not, or like Luis said earlier, people are not going to abuse these things that we offer to patients that are above and beyond. When Luis said that he gives them their WhatsApp phone number, those patients are appreciative that you're actually doing that, and they're not going to lose that privilege by abusing it. And I think it's the same with extending some liberality when it comes to the financial setup for these patients. We will still maintain a very good stream of income. We're very fortunate that our profession allows that to happen, even if we don't have patients coming. And I think it's just maybe the right thing to do.
I think, sorry, coming back to John, I think that today C19 will make us to redefine orthodontics as we all have been doing in the past. Because of course, it's a big problem to have active appliances that are working because you have to stop them. And this is generating a big problem for us, for our families, and for the patients, because probably we can be the ones that are promoting or spreading with asymptomatic symptomatology of C19. We could spread on top of our patients the pandemic, right, or the epidemics. So it's very important to redefine how we approach the treatments, and to C19 will change completely orthodontic specialty, in my opinion, by far, no? And this is something that it's important. In relation to the emergencies, I think, and virtual emergencies and virtual appointments for our patients, to us, I think all of them are suitable to have virtual emergencies. And I have been for 3 weeks at home, and I have not seen any patients. And the emergencies that we have seen are emergencies that has been easy to handle by telephone, not by video conference, by telephone, just talking with the patient. Then there are a small percentage that then face-to-face, it's interesting, but by telephone, it's more than enough. Many scenarios can be perfectly solved with a telephone if we work with but I also think a lot on the doctors that work with complex mechanics and appliances that are active, because I think they must suffer a lot in moments like those, no, in which you have appliances that are working, or having strong emergencies of breakage that you cannot say no, and then you're breaking your quarantine. Everybody's breaking their scenario of social distancing, and it's putting in danger the life of the patient and our life, no? And something is to think about. This is a very serious pandemic, and we have to be very serious in terms of prevention. It's something that is not a joke, and is a very sad moment in which is dying a lot of people of this illness, no?
Thank you, and I couldn't agree more. Let me, final question for this section. For those emergencies where you do have to end up in the office, to relieve pain or whatever it might be, have any of you on here changed your PPE protocols as far as type of masks you're using, taking care of your assistants, things like that?
Yep.
The only thing that we have done is continue to ask the questions of the patients about their travel history, and to see if anyone in the family is ill, also taking temperature, and changing a little bit about the way we see the patients, having them come in only one at a time. Ask the people that bring them, if they're children, to either wait outside or wait in the reception room, not come to the operatory. Just trying to reduce that spread. And it's it's hard, but it's a necessary step if we are going to take that risk and see them. And because as it was said already, we have the risk of transmitting the disease to others. So it's hard.
Gail makes a really good point, and especially with taking temperature. As far as the evidence that we have right now, the most certain identifier for somebody that is in active infection phase is an elevated core body temperature. There are more and more anecdotal reports coming out that you can be infected and spread COVID-19 with no symptoms. There hasn't been anything that's demonstrated that with great certainty. It has been all by deduction by epidemiologists that are making assumptions when they're starting to track and trace individuals that were infected. It's probably likely that they can, but we don't have any evidence of that right now. I think the most important thing is exactly what Gail said: a brief questionnaire. Everybody else sits out in the car in the parking lot, and then take a temperature. And if they are febrile, then don't see them unless they are bleeding at the time. It's just not worth risking your staff here. We do know now that the virus can live, some reports, up to 9 days on stainless steel. Now, that's been revised a couple of times, but it's certainly more than 3 days, probably less than 10. But if you think about that, that's haunting, because if somebody misses an area of wipe down or whatever, that's another week that a patient can come in and be infected. So just like Luis said, we've got to take this really, really seriously and make sure that we're not contributing to the spread, nor are we bringing it home to our families.
Pay attention also, because, since that it's very important to aerate what you're doing, because what is going to happen is that, this is going to stay around the air for a while. So open the windows and clean everything. So make a safe area where you work. And then after you work, patient out, you clean everything and you change yourself. And please, 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 don't touch.
Yeah.
Don't touch telephones.
Beautiful
Don't
point.
touch computer. Those are terrible things, because there are only 3 ways of getting infected. But everybody, droplets, etc. But your hands are the worst part. And I don't want to go back home and infect my family. Every single time I go in my office, I change completely. And before going home, I take a shower.
I want to add one thing.
Another
Go
discussion.
on, Mark.
We're getting into another discussion here of how we're going to practice differently in the future, and we're present when we see emergencies. I mean, there are lots of things we have to think about. One easy thing to do is have them change all the filters in your HVAC systems to HEPA filters. I mean, that's just the easiest and cheapest thing to do, and it's a big help. We're going to have to do things with negative pressure rooms if we're going to use any handpieces, so that kind of aerosol doesn't go out into the offices. We're going to have to separate patients further than traditional bays. These are all things to think about now. And I mean, we're already thinking about when we're scheduling patients in the future that we're going to only schedule every other chair in the bay so we can keep people further apart. And this is a great reason to keep parents to just coming with the child and not the family and the family friends. And you have 9 patients in the office, but you have 22 in the waiting room. None of them are patients. So right. It makes for great fun. It's a great way to build relationships. Everybody says, I love to come here and see my friends, but it's not going to be the future. I did find that note from the ADA on March 31st. And on the lower left-hand corner, they say dental non-emergency procedures. And they say orthodontic procedures other than those to address acute issues, pain, infection, trauma, or other issues critically necessary to prevent harm to the patient. So that leaves it up to us to say what's critically important to prevent harm to patient. An overly active appliance can create harm. Reverse curve wires could do it. So it really puts it in our hands. I just don't think they're going to be that hard on us.
Very great point. Thank you to everybody. Dr. Kravitz, last comment on this section, then we're going to move to finances.
Yeah, listen, I I hope we don't have to have negative pressure rooms. I do think we might do dividers between chairs, and I think there may be, as I say, business as usual will not be business as usual in the future. There will be some modification to this. But the bigger problem is the only way we are not going to get COVID in our office as doctors is if a patient with COVID doesn't come into our office, because there's nothing we can do. Dentistry is there's no way we're going to be able to contaminate aerosols. There are doctors and physicians who have much better coverage and personal protective equipment than we are wearing, who are still getting sick. If we are close to a patient who is sick, I don't know how we can truly prevent aerosols. And that is why I think we have so many orthodontists who, even if there isn't a governor mandate saying, why am I even working? I'm going to be a major cause of spread. I think a lot of orthodontists, without having a mandate, even if their state or their society has left it open for them to work if they wanted to interpret the rules that way, them saying, this isn't an ethical thing. This is an ethical thing. I can't work. I'm good. I have such volume. There's no way I can contain this. So I don't know. Go ahead, John, please.
No, I don't want to interrupt you, but I just wanted to make, that's a really good point. And I know that we're going to be discussing this at another webinar, but I think that everybody ought to be thinking, Gail brought it up, Mark brought it up, I think everybody needs to be thinking about legislatively, what are we going to do to protect not ourselves, but what are we going to do to protect our profession? Because what's going to happen, that I fear greatly, is that OSHA is going to make blanket statements for all dentists, and which orthodontists are such a unique breed. The way that we treat, the way that we see, the way that we appoint is completely different. And it could truly bring our practices to a grinding halt if we allow sort of generalized OSHA, newly mandated post-COVID legislative movements to happen. And my point is this: we need to be proactive and active right now in helping to form and mold what those recommendations are going to be, whether it's by contacting your senators, your state representatives, leadership at the AAO, leadership at the ADA. We need to make sure that we're loud and heard when we are interfacing with new regulations that are without a doubt going to be coming down the line post-COVID, as far as how it impacts our private practices across the world.
And I'd like to say, beyond the regulations we might get, we're going to get regulations from our patient base. And you know how people talk in the community. I went to a meeting, and I went to the Shulman meeting in California, and I came back, and one of the mothers said to Dr. Salzer, how could he have gone to the meeting and come back to the office? And I don't want to bring my child in because of that. And it's not, I can understand what she meant, but and you only need one mother like that, and that's 100 mothers. So perception is reality, and we should go out of our way. For example, like we're going to re-sterilize every appliance coming back into the office from the lab, and put a note on it saying we've re-sterilized this since we returned from the lab. We give them peace of mind that we're covering this. You don't want them waking up in the middle of the night saying, I wonder if anybody cleaned that retainer before they gave it to my child. These are all the things that we're going to have to think about. And Neil, the aerosol thing is a big thing. It was in dentistry before. We escaped so many things as orthodontists. When I started in practice, we didn't wear gloves. We used cold sterilization only. You put it in a tray full of blue liquid, just like the barber shop. You took the pliers out when you needed it. That wouldn't fly today. So
one thing very quick. Sorry, Mauro.
Go ahead, Luis. Go ahead.
You.
Okay. Now I want to say just something optimistic. This is going to be temporary. This is going to be temporary. I mean, two things. Our profession will not be like it was before, for sure. We're going to be a little bit different, but this is going to be temporary, because all over the world, they are working hard to do something, to prepare something against this virus. So I'm pretty sure that within I don't want it to be too optimistic. 6 months is going to be over. But we have to be in this 6 months, this window, we have to be very careful. But it's going to be.
Yeah, well, I was going to say that how many patients are we going to be able to see every hour after CD19? How many patients? Probably 1 an hour, and then clean the air, clean the surfaces, clean everything, change clothes for new scenario. Until we don't have vaccine, the scenario that we have is, economically speaking, for the office, is not possible, because an orthodontist seeing 1 patient an hour is not working. And the same is going to happen regarding to all the scenarios. So it's very important that we redefine the protocols for post C19, no? For a scenario in which we are able to space and maybe treat our patients in a total four appointments in a total. Complex cases in 4 appointments. Then it's something that it will be feasible to work with, because the scenario will be this one.
Yeah, that is what I'm having great trouble with, because let's say, like Mark, for example, Mark, let's say there's a date where they say all New York orthodontists can go back to work. They have that date in Virginia, for example. But that's not going to be, like you said, Luis, business as usual. I can't go 100 miles an hour once we get started. So what I am doing is, on the day that I'm allowed to go back to work, that day is extended very late, because I have to thin out all the patients and bring them later into the evening. That doesn't even make room for the people who I've had to reschedule. And that's why this is going to take, I agree with you, Mario, this is going to take 6 months before we're even into our natural flow, because not only do I have to reschedule patients, I have to thin out the ones on the days when I'm allowed to go back to work.
Yeah, I mean, very, very good points, Neil. You know, I look at it also, and I think so much is going to change for that. But I'm going to save that for the next webinar. Let's move into the next section. First up, thank you to everybody that was in this section. I learned immense amounts. Don't leave me though, Dr. Kravitz, you're on this. So I'm going to turn the time over to Wes Lyon from McGill Hill Group, and let you take the reins.
Sorry, great, thank you. So there's a lot of good news that came out today. For everybody in the United States, at least. We got a frequently asked questions released on the payment or the Paycheck Protection loans. So this loan is really the best way to access funding for orthodontists in the US. The loan is eligible to be forgiven up to 2.5 times your monthly average payroll cost. So really it's 8 weeks of expenses that are going to include payroll, rent, utilities, and interest, and the loan will be forgiven if you follow the guidelines at the end of the 8 weeks. Up until today, there's been a lot of interpretation, but for everybody on the call, most of you should be applying for this loan through your local banker. They will need to be SBA approved. So what we've been unclear on up until today is, what does payroll actually consist of? And we got some clarity. So it's going to include wages, healthcare benefits, retirement benefits, and state unemployment taxes. Now, where there really wasn't clarity was there's a $100,000 annualized cap on anyone's compensation, and we needed to know, is that including retirement benefits, healthcare, or is that just wage compensation? We found out today it's just wage compensation. So for those of you with 401k profit sharing plans, defined benefit plans, you can have your own compensation up to $100,000 included. Then you're going to add on healthcare after that. Then you're going to add on your retirement plan benefits after that. So this substantially increased the amount of money that's going to be available to you through this program. Now, there's a couple things to be aware of. First is 75% of the forgivable amount must be spent on payroll cost. So if you get this money, let's say you get $100,000 and you only spend $70,000 on payroll costs, part of this loan is not going to be forgivable. 75% needs to go to payroll costs. What this means is you get the money, you bring the staff back. That way you have that covered. Since it is 2.5 months of payroll, you should have that covered in the loan anyways. And that also brings up the benefit that you can use for that other 25%, which is really going to be the things you have to pay anyways. Other things to note, make sure you keep track of these expenses. We're telling some of our clients, if you want to open a separate account and then just transfer funds every time you make a payment. So let's say our payroll hits and we've got $100,000 in the loan account. Now we just want to transfer, payroll's $23,000, transfer $23,000. Cover the payroll, make sure we keep track of that. On the front end, the banks aren't going to be held liable for how much the loans are given. It's up to you to make sure that that's correct. But on the back end, the forgiveness will likely be strict. Other things that we found out today, if you submitted a loan application already, and now that we find out there's new rules today, you can go back and revise your application under the new rules. Also, if you interpreted the law differently and submitted an application, you will be held harmless for the time that you submitted the application. But I would assume that most people, if they already applied, this will be good news and they may be able to actually increase the amount of the loan. And then one other thing, which I cannot confirm, it's feedback I've heard, but it's something to check with your local banker. We did have one client get approved for this loan. The bank actually was able to push back the date that he is going to receive the loan. So I cannot confirm this 100%, but basically you want to apply for the loan now because the money will run out. Now the money could get replenished, but we don't know that for certain. So we want to go ahead and hold our money now. This client was able to postpone the date that they're going to receive until May 1st. So I can't guarantee that, but it's worth a shot for all of you. If you can apply now, get approved, have your loan funds available, but not take them until the day you're going to open. That's your ideal scenario, but you'll need to check with your banker on that.
Awesome. So we have Dr. Carrier for Europe. What do you have going on right now?
Yeah, in Spain, I am in Europe. We are several countries, and all of them their internal policies. But in Spain, dentistry and orthodontics, as is included in dentistry, has a scenario in which has been declared a necessary profession. Out of the confinement, they say you have to have your office open, and these exclude us of any aid from the government side in terms of helping, because you have to close your office. So we have the office closed because we don't want to spread the pandemic. And we are solving virtually the emergencies. Our staff is at home, but we need to cover all the expenses of the staff and this. The only thing that we have is a help on having loans in which we have very good scenario for paying back these loans in 2 years, no? So this is the problem that we have, and this is the maximum stress that we have here in Spain, particularly in Spain. I don't know if Dr. Cozzani has more feedback on Italy, how it's going, but this is the stress of the profession, no? The profession that we are today holding all the expenses of an open office without the help of the government at this point, no? Basically.
Luis, no help in Italy.
Same?
Yes.
Open your camera.
Do you really want to see me?
Now we got you.
Just few things and not even coming, so not a good situation. Let's put this way.
Excellent. Thank you.
You're welcome.
And thank you to Wes as well on that. And quick question. Let's go to Dr. Fry on this one. As we start talking about your employees, I know there's been a lot of talk between furloughing and firing and keeping them on and using the lending that's coming from the government. What have you chosen to do in your office, and what's working?
This honestly was one of the hardest things I've ever done in my professional life, is deal with this. And really, I had to take a step back and look at this. I really believe our story about this topic really wasn't about bills or laws, as much as it really is about leadership. And all of us as orthodontists are leaders of our teams. And I've always believed in being a servant leader, and I felt like it was my job to do anything in my power to ease the burdens of our team. And so really what I chose to do is to really do two things: just provide consistent communication to them and figure out a financial solution for them. Just like most of us in the world, we were staring down the barrel of being shut down for an indefinite amount of time. And for me, having over 100 hourly employees not get their paycheck, I really owned that. It really hurt for them. And really, I saw three options. Number one is we could just come to work and just defy. We could furlough our employees, which I viewed, and I'm sure they would view, as being fired. Call it whatever you want, or some type of hybrid. And honestly, my job, I thought, was to try to figure out what that hybrid was really going to be. Philosophically, I believe that most of big problems like this are solved with great leadership, and it became increasingly clear to me that this was going to be kind of a big leadership moment. And I'm sure all of you felt the same way. My decision was to really buy time for the government to get their stuff together, and my decision was really to take the hardship of my team off the table for them and sort out everything else that needed to be led through. So what we did is gifted our entire team a week of extra PTO. For over 100 people, it was a sizable expense. And although it was expensive, it really wasn't a hard decision. I really believed that that's what we stand for as a company. And when on March the 22nd, our governor canceled schools, and then there was the stay-in-place order that I'm sure most of you are experiencing now, we're essentially shut down for a whole month. And so our leadership team, which consists of my COO, my finance director, HR manager, and 4 operations directors, we began meeting every day on video meetings to figure this whole thing out. And our first meeting was nearly 3 hours trying to figure out, okay, how does this moving part work and this moving part? And that was hard enough. Thank goodness I didn't have to, at the time, really figure out how my employees are going to put food on their table. And by that time, the Families First legislation was kind of in the works, and there were many discussions about this paid sick leave versus unemployment, and everyone had an opinion. Even very trusted advisors had different opinions on whether that stay-at-home order was really a qualification for that paid sick time that was going to be offered on April 1st. I really believe that it was my first obligation to our team by eliminating that confusion for them. So I began emailing them twice a day with clarity, telling them what was going through my mind, what the government was saying, what I was hearing, but in a way that was easy to unpack for them. That then kind of transitioned to once a day and trying to lead through that constant communication. But that week of PTO was starting to wrap up, and I knew that by the end of the week, they were going to start to be nervous about where their paycheck was going to come from. And in their minds, I knew that was a big deal. And so I needed to be a calming influence at some level as a leader. And by the middle of that week, even with all the opinions out, I knew I needed to make a decision about what we were going to do with this paid sick leave. And I really chose, I believe, the riskier financial route. And I made that decision that I'm going to claim they all qualify for that paid sick leave. I know there's some risk in that I could be taking on an extra 2 weeks of PTO time and penalties or whatever that might come with that. But I really felt confident that we were doing the right thing. And I believe that was the intent of the bill, was for us to try to help these people. And I slept better after making that decision, because I knew that my team didn't have to worry about putting food on their tables and paying rents and mortgages. So really, the decision bought us another 2 weeks. Then the CARES legislation was passed. We applied last Friday and were granted that loan last Friday, actually. And there really are a couple takeaway messages, and I'll let somebody else talk about their experience. But really as a leader, three things: to continually to communicate clearly to your team in times of crisis. Number two, to keep your team in the forefront of your mind. And three, to err on the side of your people's best interest. And I know that our team is extremely grateful for that during this tough time, and they don't have to worry about the money. They can simply take care of their families and their own health. And I don't know that that's the right decision for everybody. That was right for us. And I appreciate you letting me share it.
Dr. Fry, I'm inspired by how you treat your team. From a financial perspective, going back to Wes for just a moment, what is McGill and Hill recommending right now in regards to this?
Sorry, I had to unmute myself. It really depends on what the doctor's done up until this point. For most doctors, the what I'm going to do with my staff question has been answered already. So they've either made the decision to keep them on, or they're either furloughed or laid off, and I kind of leave which one we're going to do to an employment attorney. Generally speaking, people are in two camps. One, I can afford to continue to pay them, and I'm generous enough to do it. Or they're in the second camp of either I don't want to do it, or a lot of people quite simply can't afford it. So for the doctors younger in their career with debt payments on a practice, it's not feasible to pay the staff for a couple months and still pay the bills. So for those people who have already laid off the staff members or stopped giving them hours, then really it's just simply apply for the PPP loan. That's kind of been our judgment on day one, is this PPP loan's going to be the best thing for you for the different options that are out there. And the real reason is, one, it gets the staff out of the soup line, so the staff is no longer on unemployment, although if they do collect that $600 a week, some of them may be better off. With that in mind, I know here in North Carolina, I've talked to a few doctors trying to approve their unemployment, and it's just not happening. The website's down. They're not even answering phones. So whether or not your staff is actually going to get the unemployment is a whole other ball game. But generally speaking, it's just apply for the PPP loan and try to delay the funding up until you're back open, unless you're paying the staff anyways. So some people are in stay-at-home orders. Some people have their employees come in, although they don't have patients coming in. We deal with all 50 states, so it's different everywhere. But if you don't have them currently on the payroll, get the PPP loan, try to get it funded as late as possible for when you open up your doors. That way you're getting the benefit when you need the staff, and then hopefully they get the $600 a week. If you are continuing to pay your staff all the way through, then you likely want to take that money now, continue to pay them, and then hopefully on the back end of it, we'll be back up and running. Or this is an election year, and hopefully if the money does run out, or we get to a point where the 8 weeks is up and we still can't open our doors, we hope there'll be some additional relief coming in, but we take that decision day by day.
Quick follow-up to that, Wes, and thank you. What PPP, does it, above wages, what else can you pay with that? I mean, are we talking healthcare, retirement benefits?
Correct. So payroll costs are actually going to include basically everything to do with your payroll besides salary above $100,000. So for the doctor, any associates, or if you have a spouse making above $100,000, or larger practices might have an office manager making that if you're large enough. But healthcare costs are going to be covered, so they're going to be part of the calculation. The state unemployment taxes are going to be part of the calculation, and the retirement plan benefits are going to be part of the calculation. So in healthcare, if you're making HSA contributions, if you have a health reimbursement arrangement, a medical reimbursement arrangement, or if you're just paying the insurance premiums, that's all going to be covered in this calculation, and it's going to be forgiven on the back end. So basically your entire cost of bringing your staff back minus additional cost for associate or highly compensated employees with wages above $100,000 on an annualized basis should be covered. In addition to that, you can pay rent, utilities, and interest on debt previously incurred. So if you have mortgage interest, you have interest really on any practice loans, that will be forgivable as well. So 75% of it does need to go to payroll costs. That includes yourself up to a certain extent. And then rent, utilities, and interest is what else it's going to cover.
Excellent. Thank you, Wes. Dr. Kravitz, question for you. When we look at our patients on payment plans, I know there's been a lot of discussion. You just keep letting everything roll over, or are you giving them the option to delay payments? What is your practice doing?
Sure, absolutely. First, can we just say how great Jeremy is? Jeremy, I just I love it. Listen, I'm serious. This is like for real. I don't know if people really understand the stress we feel as owners to take care of our team. We love our team. We will do anything for our team. We are trying to find ways to give them whatever we can give them, paying ourselves last, if at all. And Jeremy, you are leading the way, and that was awesome. And this is an opportunity that I think for every owner to really develop incredible rapport, whether it's a Zoom meeting that you're just doing or whether it's added PTO. I thought that was awesome. And I know that when they come back to work, they are going to be your employees for life, and they will forever remember what you did at a time of need. So I just loved it. I actually I have so many questions for you because it was awesome. Thanks. So Mike, ask the question again in terms of payment. So here's the thing. I really we closed in March, right? So the first payment happened April 1st, and then we'll have another one mid-April. We charge the first of the month and then mid-month. The first of the month, I asked questions to our team about it, but we decided to go ahead. It's that May 1st that I'm nervous about, because now I've been closed for over a month. I've now missed a cycle of seeing people, and I can really envision people starting to say, what am I paying for? It's already a problem for a patient who might finish early in treatment, let alone someone who's not being seen and can't be seen. It's no different than a parent who's questioning why they paid their private school tuition or college tuition. These are problems that are going to have to come up, and people. So I don't know what to tell you other than it is a ongoing discussion, and I will be very open to anything. Certainly, if a patient wanted to defer, even if I felt like maybe I have to discount, I would be open to it. But all the rules are written in sand here, not stone. I'm open to anything, and it is a constant decision. A lot of these decisions, just like Jeremy said, are going to be stomach decisions where I say, how will somebody feel if they are in a difficult situation? So as of right now, as of mid-April, April 15th, I am gonna run credit cards. I love John's idea of putting a notice online, and I will do so. But the way the world works on Yelp, it just takes one. It just takes one person, and I would hope people who need help reach out to me, because I would do whatever I can do to not be another source of financial strain to them.
Awesome. Thank you, Dr. Kravitz. And so I'm gonna move to you, Dr. Fry. I have two offices, and we've given patients the option to defer. And only 9 or 10 people have taken us up on that. What have you done in your office, and kind of what have you seen people either take advantage of, or what's gone on there?
Well, we've been really more reactive than proactive on this. I think what I'm doing is I'm having my financial team track everybody that's calling every single day asking for help. And what I've given them the authority to do is figured out. And, we went to our landlords very early and came with a plan and basically said, okay, can we have 3 months rent abatement and then pay it before the end of the year? And I felt like that was fair. And I felt like if I think it's fair for me, should be fair for our patients. Hopefully they can get through, whether it's a month or 2 months or 3 months, whatever it is, but listen to what they're asking for and figure out how to make it right. So instead of posting it that we're willing to do it, even though we are very willing to do it, I'd rather be more reactive. I'm not sure how I feel about being more proactive. I think I'd probably, we probably have more patients that decided that they wanted to take a break, which is probably going to happen anyway. But I've been shocked at the low percentage of patients that are calling in. Now, our delinquencies have gone up. We track that every day to kind of see, okay, what is our trend and what are our numbers? And that's ticking up quite a bit right now, but not crazy. So I don't know that I have a good answer for it, but that's what we've done.
I want to add to this 1 second, Mike, for Jeremy, because my concern is like when we're ready to get rocking and rolling, how many consults are going to be financially ready to actually begin treatment other than maybe a down payment so my concern is not just numbers of patients but it's not, I don't foresee everybody being financially ready to work, particularly if they're still not at work, even if we are open. And I do have a concern about that.
I think you're absolutely right. I don't know. I mean, I hope that the government I hope their plan is going to take people into account. I hope the people are going to get their payments. I hope people are going to make their money from this PPP program, because that money should be going directly back into the community. And I think the design of that is good enough. I mean, who knows? So I guess this is where you go down this road of, okay, well, how flexible are you going to be with your down payments? How flexible are you going to be with your monthly payments? And I think those are big questions that all of us always wrestle with. And I think I don't have a good answer. I don't know. I think I hope. I'll be honest.
Whatever. It's yes. Well, whatever it takes. Whatever it takes.
Exactly right. And but if any, like as of right now, since we've closed, and I know you're against this, I've done 30 new exams video in the last 2 weeks, and almost all of them signed up. And this is in the heat of them thinking that they're out of work and everything else. So I don't know why they would sign up. I don't know why they would want to come, but I mean, those first days back, I'm hoping are going to be jam-packed full of new patients. I don't know where this is going to go, though.
Great discussion. I love it. I wish we had, even more time for this. Let's move into the next.
I think this is like around the horn, right? It feels like around the horn right now.
Isn't that
I hope
true?
I'm not getting graded.
Yeah. Oh, I've got the grades back here.
You're going to shut my video off here in a second?
Yeah, you're good. So for the final section before the question and answer, and thank you too for that, and thank you, Wes. I mean, your insights are invaluable. Coming to what can we do for our community? We've talked a lot about our offices and a lot about how we can manage our staff and our finances and things, but now looking to kind of move outward, what can we do to help our communities? So specifically asking Dr. Glenn and Dr. Graham, what are some things that you can do to help in your community?
One thing that I've noticed is our dental society has put out an alert that they would like to take any extra PPE that anybody has from their offices, any stores of masks and gloves, and they're delivering them to healthcare facilities and Children's Hospital and different places like that. I hate to say this, but usually we don't have a huge backlog of that kind of thing in our office, but in one respect, I'm a little bit selfish. You don't want to get rid of all of it and then not have any when we're ready to go back to work, because we can't go back to work without it. So I think it's great if people have, large excesses, but I know that there is a community need. So I guess you have to balance that within, what you have and what's available and what's needed. That is the only thing really in the community I've seen. I do think that we need to have some contingency plans if some of our colleagues do come down with the virus when we're up and running, to have some practice coverage agreements and those types of things within study clubs or communities. And, we certainly hope we don't have any fatalities through this in the orthodontic community, but those are things we have to think about.
Yeah, I was going to mention, Gail, those are really good points. And I think that one of the things that you can do, I mean, all of us are healthcare professionals, and it is not a bad idea to reach out to your local, your city, whoever seems like they're in the most need, whether it's a large hospital, a university hospital, and let them know, hey, listen, I'm an orthodontist, but I can help any way that you want me to. I am certain that there is a need for a lot of healthcare professionals that they're running short on right now. I know that for a fact. I'm also a physician, and we got an email from the Utah Medical Association, and the email said, we don't care what kind of a physician you are. We don't care if you're a psychiatrist, a pathologist, or a diagnostic radiologist. If you're a physician, we need you. And please put your information down. Tell us when you're available, and then we will reach out to you. And when the time comes. The same goes for dentists or doctors. Come on, we can do whatever they need us to do, whether it's taking vitals at a triage at a hospital, whatever it is. I think that the greatest store of value that we have is ourselves being trained professionals who understand the ins and outs of infection control. We understand how to handle large volumes of patients. There's a lot of things that we can do that we don't typically think of as orthodontists, besides just seeing dental patients. And so for those of you that really feel the urge to help, I would start by reaching out to your local medical association and just call them and say, listen, I want to help in any way that I can. They may say, no, we're okay, but they may say, thank you for calling. We actually really would benefit from having somebody come and do this, and this, and you'd be surprised.
I think that's wonderful advice, and especially in a time like this, I think giving back is one of the best things we can do for our communities. Let's move to a few questions. There have been literally hundreds of questions asked, but I'd like to take the time to answer at least a few of them. So. Dr. Fry, if I could have you come back up really quick. Somebody had asked, you mentioned with virtual consults that you have done, you had 30 patients sign up just in the last couple of weeks. Are you taking payments on those individuals? What is the next step for them?
Okay, so the way that we run this, one of the things I said in the beginning was I wanted to make it systematic as much as it can be, like an in-office exam, obviously without records, and without, generally records and a true exam. We can't get everything, but what we do is that we go through our video exam process. I have somebody in our office that is in charge of all of our video exams, who then calls that patient after I get off the video with them, goes through all of our financial options and finds out a plan that works for them based within our parameters, and then gets them signed up. When they come in for that appointment, it essentially is a start. So we see them right away, but we get full records, and we do just a verification that the plan is right. If I screw up and miss a small lateral or some, maybe it's more class 2 than what it looked like, maybe we change that. We don't change the payment structure. We might change the time on it a little bit. We may, which is communication with them, but essentially it's adding an extra 20 minutes to a start appointment, and they come in and they already know their contract amount. They already know how it's going to go. They know the date, and it's pretty nice. I mean, they start right away.
And you have a disclaimer, you said, a disclaimer for, during that virtual appointment that you're going to go through the records once you take them?
Sure. I mean, we talk about it very informally. I'm sure you can be more formal about it, but again, I try to reduce barriers for starts. And I think if you just tell them, hey, listen, we're going to double check this when you come in, and we're going to make sure that everything that I thought I saw on video is in fact the way that it is in your mouth. And kids sometimes they bite funny, and they're all over the place. And sometimes you kind of have to wing it, and you kind of know it's going to be in this parameter. They're either a little class 2 or they're pretty good, but it's still going to be about the same time frame. The price is going to be the same. It's pretty simple. Yeah. And then they get signed up, they come in and you verify it, and then you go.
Excellent. Thank you so much for that. Dr. Glenn, if I could bring you back up for just a minute. I know you're very involved in organized dentistry, and there have been a couple of questions about what the ADA and what the AAO is doing for lobbying for COVID testing, not only in our offices, also kind of what the plan is from here forward. Can you just give a quick synopsis of what the AAO is doing?
I don't know specifically about COVID testing and things, but I know that the Board of Trustees has been on conference calls daily, many times daily. They've also been conferring with the ADA and the dental specialties groups. So they're all really working together collaboratively as dentists and trying to handle different issues. As we all know, the information is coming in so quickly, and then you barely get something read, and then something else comes in, and it's an update. So we know that a lot is going on, and it's really hard to keep up with it just in our own mailboxes. So I can only imagine for the leadership at the ADA level and the AAO level. But I know that they have our best. I know the AAO has orthodontists' best interests at heart. So I know that they're working, and it is always difficult to get the information to the ADA that we want, because the ADA is so much bigger and they're looking at more global things, and then the AAO is trying to narrow it down for the good of our specialty. But I do know that they're working every day.
Second question for you, Dr. Glenn. Has the AAO, so as we see emergency patients, there's been a few questions on recommendation to have a secondary in front, anything in that regard. Does that
sorry,
make sense?
Cut out just a little bit. Answer the question one more time.
I apologize. Has there been any recommendations from the AAO as far as emergency patients? Should we have a secondary informed consent specifically about COVID?
I have not heard anything about that. I have not. I certainly wouldn't hurt, but I've not heard that. Just more the screening ahead of time.
Okay. Anybody else? Has anybody else on the panelists done anything in regards to a secondary informed consent for those that you're seeing? Okay. Let's move on. Phil, I know you had a question that had just come up. Can you ask that one for me? The list is long.
Sure, no problem. So this question is about the virtual waiting room. Just for people who aren't as familiar with how that works, I think Dr. Lemchen, if you could come back up, I think you were discussing that earlier. Just the question was, is it people zooming in and waiting to be granted access? So just a little additional detail on how that works for the patients. And if not Dr. Lemchen, then anybody who feels familiar. Oh, okay. There you are. Okay. I'm here.
So we use the Zoom waiting room, and really so you bring them into they get an invitation to join the virtual meeting. When they click on it, they're placed in the waiting room. The host, which our assistant is acting as the host, when they're ready, we'll click on them and bring them into the meeting with them. And so then I'm still sort of waiting in the waiting room because I'm not hosting this meeting directly. And then once she has them all set up and ready to talk to with me, she will click on them and click on me and bring me into the meeting as well. So it does two things. It keeps everybody sort of in one place. It also is an extra security item where somebody cannot Zoom bomb you, as it seems to be the phrase, and become part of your meeting without you really knowing it or seeing them. So it's got a security purpose, as well as it literally is a virtual waiting room. They're sitting outside waiting for you to bring them in. It works very well.
Love it. Thank you. A financial question, Wes, for you. A couple individuals had asked in regards to the PPP loan, if, we're trying to delay it as far as we can so that we can access as much of the funds for our practices. Is there a chance, or are you worried that the funds might run out if we delay too long?
So there's kind of two parts to this. The first is the application part. I'm recommending all my clients apply now. So once they apply and they get approved and their money is appropriated to them, that locks in their funding. Now, this is going to change bank to bank. So ultimately, you need to discuss this with your banker. I've heard, I think in the chat here, some people said their bank wouldn't do it, but I had a client confirm this morning their bank did delay the actual funding. But once their funding is approved and allocated, it's taken out of that funding. That's done to our understanding. But again, this is really, from my standpoint, it's an idea, and if it can be executed, great, but make sure you cover this with your banker before you just assume.
Mike,
Yes.
may I make a quick comment? And that is
Please.
that I think a lot of doctors, or a lot of everybody is getting hung up on the idea that once you receive the money, I mean, once the application goes through, you receive the money and the clock is ticking. Here's the reality. Everybody is asking the question, are you going to be ready to see patients? No, but the point is I can have all of my staff doing things every day to justify a full payroll for all of my staff members, even if it's not seeing patients. I can have them contacting patients. I can have them going through our charts, updating. There are so many things that I think that we're getting hung up on the idea that, hey, you should pause this until you're actually seeing patients. That may not be possible, but even if it is, what's the point? If you are just demonstrating that you're paying your staff right away and you're doing so, I mean, I can't think of any of us that would not have a full list of things that every single staff member could be doing every single day, given the predicament that we're in right now, to prepare our offices for the time when it's ready to see patients, whether that's ordering, whether that's inventory, whether that's checking patients' charts and preparing them, going through Invisalign, whatever it is, it doesn't make any difference. So at least for me, I'm not hung up on that at all. I'm not hoping that this can be delayed or anything, because what I'm worried about is that the funding is going to run out. Now, we know that Steve Mnuchin this morning mentioned that the Department of the Treasury really wants Congress to allocate more funding for the PPP. But again, that's a congressional act that has to be done by Congress. We know, my banker had sent me an email yesterday saying that they're anticipating now that $1 billion an hour is going to be allocated starting yesterday, which means this funding is going to dry up by Wednesday, maybe Thursday, gone, totally gone. I mean, that's one of the reasons why Wells Fargo said yesterday, we're not taking any more applications. Part of it was because they got to do all of the detailed work, but the other part is there's not going to be any money. My bank is still working on the IT to get it ready to go. So I may not have access to these funds, which is why I'm not doing anything that would in any way risk my slowdown of my application. Just my thoughts.
Excellent. I love that. Another subject, Dr. Lemchen, since we have you right here. Now with virtual appointments, we've had it asked a couple of times also, and Dr. Fry, I think this would apply to you as well. Are you taking payments for any of these things, for virtual consults or down payments? What are your thoughts there?
I think every case is sort of individual in this sense. You know, if you're just sort of assuaging someone's concern that you haven't looked in their mouth for a long time, I think that's you know, they only take a few minutes. I'm more comfortable not charging for them. Addressing the other question about whether we're allowing people to defer their payments. We've taken anybody that asks about it. We certainly have decided that we're going to be as gracious and accommodating as possible about that, because you're going to end up doing it anyway, because if they ask for it, they're going to stop paying anyway, or they're going to, they're not going to keep paying because you told them to. They're really asking just for you to give it your blessing. And if you're going to give it your blessing, you might as well get credit for it. So be the big person at that point and do it. I think, you know, we followed the same role as Jeremy. Actually, we paid our staff. We paid them the first 2 weeks without any question. And then we felt we had to cut down on the hours. So we cut them down to fewer hours, and they put in for unemployment for the other hours. And we tried to give them as much work as possible for the second 2 weeks. And now that's last week, we're cutting them back a little further. We still have people actively working from home, actively making appointments, actively following up on patients. We're getting aligners in the office, and if we can, if there's no new attachments or IPR, we're sending them out to the patients. We're responding to emergencies. We've had very few emergencies also. I saw one at my house out here at the beach on the porch. And, you know, people are very appreciative and they're understanding. The mother waited in the car. I didn't want anything more than I needed. So I think everybody understands that we're all in this together. And I give my staff credit because they've been braver than the doctors as far as going into the office and managing to get there. We paid actually for their transportation in Ubers and Lyfts rather than asking them to take any kind of public transportation, just so we have that as well. This is not a time to save money. And all the doctors in the office have deferred their salaries so we can continue to pay the staff and maintain their health insurance as well. I think that's what you got to do.
Thank you.
Yeah, I can chime in real quick on this. Typically, when we do our video exams, we don't take a down payment before we see the patient and take the full set of records. One idea that we floated was kind of a creative idea to create a VIP patient that might get first preference to appointments once we kind of start back up again. Obviously, all of us know how big of a problem, bottleneck that's going to be. We decided not to do that. We thought, well, if we wanted to make them a VIP, we could take a down payment for cash flow purposes. But we kind of figured that kind of started the relationship off a little weird and it'd probably create more problems down the road. So we didn't do that. But, you know, some offices may think of that idea as a creative enough idea to try. But we typically don't take money off that new exam, video new exam.
And then one other note that I thought was, that I think we came up with a nice solution for is when we do go back to work, how are we going to spread these patients out so we don't have somebody in the office at one time? We've divided our staff into 2 teams, and we want no overlap between those teams because we don't want one team possibly infecting the other. So one's going to work 7 to 1, and then they spend their last 15 minutes sanitizing everything. And then the next team starts 2 to 7. And so we're going to see half the number of patients in those 2 shifts. We also had a professional company come in and spray the office with disinfectant, and you get them on a monthly or weekly basis. And we're looking into UVC lights that we're getting to try to do more sterilization of the entire area on our own.
Excellent. So I appreciate that very much, Dr. Lemchen and Dr. Fry. As we come to the end of this webinar, are there any other final thoughts or things that our panelists would like to share before we close? And reminding everybody that we will be hosting another webinar on how to get the practices up and running once this all begins.
John, before you jump in, I want to say one thing real quick and I'll jump off. This has been a complete honor. I really, be on this panel with this caliber of people is just an absolute honor. And I've known Mark since I was a kid, and my dad and him were in the Shulman group together. And I just think the world of you, Mark, and everything that you've done, and everybody on this panel that is here is just so gracious of your time and your knowledge, and appreciate you letting me be involved in it. Thank you.
Thanks, Jeremy. I wanted to make one quick comment, and that is a couple of people have been texting me as they've been watching the webinar, which again, thank you for the invitation to participate. It is an honor to be with everybody, with Mauro and Gail and Mark and everybody. These are just the top our profession has to offer as far as committed doctors. A couple of people have been texting me, if you do try to put your staff to work before you start seeing patients so that you can get the money from the bank as soon as you can, what are some things you can have them do? I mean, the sky is the limit. The first few things that I think about, Mark even mentioned that. I mean, a top to bottom cleaning of the office, staff can do that. They may not want to do it, but they're going to get paid for it. So I mean, when I mean top to bottom, I mean every millimeter of that office needs to be cleaned. Writing cards of appreciation to every single active patient that you're currently treating. Those are hundreds and hundreds of patients where staff could be writing handwritten cards stamped and mailed by snail mail to those patients. They could also write letters of gratitude to referring doctors, schools, referring patients. I mean, the list goes on and on. Once you start thinking about what things could we actually have our staff do that's promoting the practice, getting it prepared for opening, Yet justifying a full payroll, it's easy for me to do. It's not a hard thing at all. You just have to kind of think about it, because we've never had to do that before when it comes to this sort of arrangement, but it's not hard at all. I guarantee you, you spend 15 minutes opening your mind, you'll have 4 pages of things that you could ask your staff to do, that they will do, that you need them to do, so that you don't have to delay or go through any gymnastics in potentially jeopardizing the money that you could get from this program, which everybody should be applying for, because it's money that will be forgiven. This isn't going to happen again, probably in our lifetime. So I think it's important everybody at least try to do it. That's all I got.
Love that. Mauro,
you're muted.
On mute. Yeah.
Sorry. Thanks a lot for everybody for having asked me to be with you and to share some ideas. And it was really a pleasure. Thanks a lot.
Thank you,
One
Dr.
closing statement I had is be sure and check your state and provincial and regional regulations. The ideas on virtual appointments are fabulous. No teledentistry is allowed in Texas. So, just be sure and be aware of your local and provincial rules. Also, I think the ideas of staff working are great, but remind them about social distancing. And the idea about having 2 teams is a fabulous one. A colleague of mine from Taiwan suggested that, because he said if one team goes down, like your whole administrative team goes down, you're in bad shape, or if your whole clinical team goes down. So those are fabulous suggestions. Thank you for being able to participate today.
Thank you.
Thank you also for all of you to be giving the opportunity of sharing with these brilliant minds this beautiful webinar. And just the tips of we have here in Barcelona and in Spain, that we are one of the countries with more C19 spread, and this social distancing, take it very seriously, because it's the way to stop this mess, And now I know that in the States it's getting stronger and stronger, and the best way is to really do things as well as we do in our offices. That's it, as well as we do in our offices, and take care of every single move that we do in order to isolate from others and try to stop this problem. Thank you to you all. Thank you.
Okay. I'd like to thank everybody also, and say I think I've gotten more from this seminar than I gave, and I appreciate it. And everybody take care.
Awesome. Thank you, Dr. Limpton, and thank you to each one of you that has been on here. Each one of you are my heroes in orthodontics, and to hear what you are doing in your practices not only inspires me, but gives me a roadmap to follow. And hopefully that each one of the individuals and orthodontists on this webinar today are going to be able to take away the same thing. Just a quick reminder, we are going to have another webinar coming up. We will send out emails to discuss getting back into practice. I did just get a message. Wes, do you have a final thought for us?
Hey, thanks. Sorry, I tried to answer as many questions as I could in that chat, but I know there's a lot in there unanswered. I just want everyone to know we moved all of our information about this in front of our paywall. So even if you're not a newsletter subscriber, you can go to the website. We have articles there. It should talk in more detail about it. So I apologize for the questions I didn't get to, but the information should be there for you.
Wes, we appreciate you more than you know. Thank you for being here. And thank you for answering those questions. So back to everybody, thank you for joining. We will send out another email when the next webinar will be, and be safe until we see you again. Thank you.